Okay, thank you, Dr. Shabnam. I think this was a lucid and erudite presentation by Dr. Sen. And I think this is an emerging field, fetal pharmacology, and a field where I think as clinical pharmacologists we can contribute by doing studies. I think as Dr. Somalia has mentioned, that regulatory framework is being worked out for fetal interventional studies, that is pharmacological studies. So this is a field wide open for work as clinical pharmacologists we can do. And I would like to ask about the regulatory framework, as what he was mentioning about PBPK modeling. Is it something approved by FDA or any regulatory authorities?
Yes, sir. And there are studies. Actually, in this presentation, it's not included, but there are studies, lots of studies which has been approved by FDA, and there are lots of drugs also that has been approved based upon this PBPK model.
There is the issue of sampling. So, in case of fetal pharmacology, how can we have to resort to cord blood sampling if we want to do pharmacokinetic studies, or is there any other way?
Yeah, that's the challenging issue, sir, that the three pillars for PBPK model, upon that the clinical data and the fetal sampling. Usually sometimes what is done is from the animal studies that is included, and animal study from there, again another modeling is done, and that one previously some other study was done on the fetus, and that one is actually matched. And sometimes if at all no studies is there, in that case it is mandatory to have fetal sampling and have to do the preliminary study. So that's the crux, that there is very limited clinical data, but with the data that is available as of now, we can go ahead and do a lot of work, but that is a bit complicated in structuring the model of this PBPK.
And the question is how to get fetal sample?
It's certain methods are there, I do not know in detail, but there are methods for doing this fetal sampling. Yes.
Okay, thank you. Back to Dr. Sharma.
I think there are different angles to look at this. Number one is, if you think of observational studies, okay, whether or not it is indicated, there are many situations where mothers are exposed because of the maternal indications, okay. In a normal pregnancy, healthy mothers, we try to advocate that don't use any medication unless it is really very much needed. But otherwise, in certain situations, medical conditions, comorbidities, etc., where mothers are exposed to medications, and then at the same time they are conceiving, and then in many situations, if the pregnancy is aborted for any reason, here lies a great scope that once it is aborted, and then you can try to sample that fetus and amniotic fluid and think of doing some research. What was the impact of that exposure, okay, on the fetal growth or development, okay, depending on the antenatal, okay, age, etc. So this is one way one can think of, if we try to develop do some kind of research in fetal medicine, and there should not be any kind of regulatory, limitations or anything. Nobody can prevent us. The second thing is about the other kind of research could be that the indication is actually maternal indication, okay, and when you are using drugs for maternal indication, what is the impact on the fetus, the exposure? One, of course, you are trying to do that observational studies, but otherwise there are very advanced imaging that has come up as compared to say 20 years back or 30 years back. So whether you can also think of trying to generate some data, okay, without any invasive kind of thing, just by imaging. And so this is another way of trying to capture data and I'm talking of broad fetal research, okay, feto-maternal research, or with a focus to understanding the fetus, okay, how much the fetus might be at risk of exposure, maternal exposure. Because when you are trying to treat the mother, despite we do not want, because there is a problem of selectivity, okay. So you cannot be too selective that only the mother will be treated, keeping aside the fetus. Fetus is also exposed. So one is, otherwise there is abortion, medical abortion or whatever, you get the opportunity of getting the fetal tissue, etc., do some research there. Second is non-invasive imaging, by which you can try to see what is the impact of the exposure. And the third is, of course, fetal indication, specific fetal indication for which you have to try something. And there lies the issue, how, whether we have some regulations, whether we have some guidelines, how are you going to deal with the ethics, ethical issues leading to the such kind of a trial, where I would say it's an intervention study. Up till now, most of the fetal interventions are surgical interventions. But there are also genuine areas where medical interventions will also be required. In certain areas, they are already established. But there are many other areas what we can think of. So it's good that intentionally, strategically, we have included this particular lecture in order to, okay, delve into a relatively less traveled area where we can start thinking about this. And maybe next time when we meet, maybe after a year or so, we'll see some of our younger friends, they have given more thought into it and trying to develop a project proposal, research proposal, sending it to ICMR or other funding agencies, try to see what is their, this thing. Let us start this new area which is yet untraveled. That was the purpose. And that way, Dr. Sumal has done a marvelous job and ignited our thought process, stimulated us. Let's hope we'll be in it. Thank you very much.
Thank you.
Thank you, sir. Actually, I am very motivated, and the one thing ignited me very much, that thing that you have mentioned. There was, if the baby has 21 alpha hydroxylase inhibitor enzymes, so there will be congenital adrenal hyperplasia. So if mother will be treated with dexamethasone, if this is possible, then it will be very good. If previously we can do these things, because congenital adrenal hyperplasia is, though it is rare, but it is there. There are lots of cases with congenital adrenal hyperplasia. So if that kind of things are, we can, like fetal pharmacology that trains, we can think and do that Sir has told, and you have mentioned lots of things about PPBBK, that things will help.
Another very important area is the HIV infected mothers.
Yes.
So here lies the very importance that we know that there will be transmission, and we know that these are the drugs which prevent transmission, but we are not sure that this will definitely prevent and treat the fetus. So how to handle? So this is a very important area, and here these models and all these things very much help, that if we increase this much of concentration in the mother, the drug concentration, in that case that model will predict that in the fetus this much drug will be there. So that way we can actually counter regulate and treat the fetus. So otherwise what we have done earlier is we just preventive purpose medicine, but we are not sure that how much it will help.
Yes.
Thank you.
It seems like he is very much interested in this field. It is really a unique field, and why don't we fix him to take it forward, and we will help. And there is suddenly, as Dr. Tripathi told, that this artificial intelligence, and through this, through this non-invasive methods will be there. So it is quite known, even undergraduate student knows this chloramphenicol grey baby syndrome, then this tetracycline causing these problems. So unintentionally, if mother take that, and their sample can be even from amniotic fluid or without harming the baby, the infant, we can do some works. Means it will be marvelous work. Go ahead. We'll support you.
Thank you. So the session, I think the session is ending, and so we will looking for tea break. Oh, sir, please unmute yourself if you want to say something. Please conclude the concluding remarks we want to hear from you.
This was an exciting session with three interesting presentations. I would like to thank Dr. Puneet, Dr. Akapal, Dr. Sumagia, and my co-chair, Dr. Shabnam, for this interesting and exciting session, which opens up a new vista of work and research for clinical pharmacologists. And so thank you all. And it was my pleasure to join you all for this session. Thank you.
Thank you, sir. Thank you very much. And now may I request Professor Nihar Vishwas, sir, to kindly felicitate Dr. Shabnam Ara Begum. Also, may I request Dr. Gopal, please, to felicitate all. Shumallo Datta. Also requesting Dr. Shumallo Sen to please come. Thank you, Pandu sir. Thank you.
I would like to my regards to Dr. Vishwas and Professor Tripathi.
Thank you very much. Thank you.
Thank you very much, Sandhu. Thank you.
Now we are moving forward to the next session, and that will be an interesting one. And may I request Professor Shantanu Tripathi sir to kindly chair the session. And we have with us today one of the eminent endocrinologists, Dr. Soumik Goswami, with us. He is now the assistant professor, associate professor at Department of Endocrinology at NRS Medical College. So over to Chairperson, sir.
So I'm honored to introduce Dr. Soumik Goswami, and who has already been introduced. And Dr. Soumik Goswami will be talking. The lecture topic is Continuous Glucose Monitoring, a Pharmacodynamic Tool in Diabetes Research and Therapeutics. Dr. Goswami, please.
Thank you, sir. A very good evening to everyone. So we know that there's a saying that if you cannot measure it, you cannot improve it. So measurement of blood glucose has been at the core of good diabetes management. So we know that initially, historically, ants were used to see whether urine had glucose or not. It was manually tested using one's own tongue. The laboratory tested glucose thereafter in the urine initially, later on in the plasma, and finally over the last 2 or 3 decades, we have been using glycated hemoglobin to see whether blood glucose is at control. And more or less, glycated hemoglobin is the pinnacle of glucose measurement, because all the major trials have been designed showing that if you reduce glycated hemoglobin, you improve outcomes. So the question that we need to answer today is that beyond glycated hemoglobin, do we need something more? And if that something more is continuous glucose monitoring, how is it going to improve outcomes? Is slide change? So HbA1c, we know that is a sort of an average. It's the mean glucose level over the last 3 to 4 months. Glycation of hemoglobin, glucose and hemoglobin forms glycated hemoglobin. But if you look at certain examples, for example, if you look at 2 patients on the left, the first patient has glucose levels going all over the place, very high, very low in the same patient. If you do an average, the HbA1c comes out to be 8. The second patient has small variations, but again the average HbA1c is 8. So among these 2 patients, I think it's simple logic that the patient below is doing much better than the patient above. Similarly, if you look at the other 3 examples, the blue zone refers to the good glucose level, say between 80 to 180. Anything above that is dark blue, high glucose. Anything below that is gray, hypoglycemia. So if you see these 3 examples, the one on the right has perfect glucose levels, the one on the left has hypoglycemia, hyperglycemia, a small time spent in perfect glucose level, but you do an average, all these 3 individuals have similar HbA1c levels. So these examples sort of point to the fact that HbA1c is still not the perfect marker of glucose control. It does not give us the variability of blood glucose levels from one point of time to another within the same day or between days or between weeks. So this glycemic variability is something which needs to be looked into as well. The reason being because not only for academic reasons, but it has been seen that beyond HbA1c level, glycemic variability increases the risk of vascular complications and death. 2 individuals might have the same HbA1c level of say 7.5 or 8 or 7.1, but the one with higher glycemic variability, more fluctuations, will have a worse outcome, both in terms of having increased micro and macrovascular outcomes and possibly an increased risk of death as well. So we have now moved from fasting and postprandial glucose and glycated hemoglobin measurement alone to the measurement of glycemic variability to see whether an individual with diabetes maintains glucose within a certain range, the so-called time in range. And there are certain guidelines which have stated that this is the sort of perfect time in range that will reduce glycemic variability and will help maintain A1C within the target level as well. And if you look at the leftmost bar, that applies to most patients with type 1 and type 2 diabetes, where about 70%, at least 70% or more of the time should be spent in the green zone, that is in range. Less than 5% of the time should be in the red zone, that is below range, time below range, and less than 30% of the time should be in the above zone, that is time above range. So 70% should be say between 70 to 180 milligrams per deciliter. Less than 5% should be less than 70 milligrams per deciliter. Less than 30% or less than 25% should be in more than 180 milligrams per deciliter, that is time above range. And depending on the risk of hypoglycemia or whether you have gestational diabetes or not, these parameters can again be altered to a certain extent, but the leftmost bar pertains to most individuals with type 2 diabetes. So the next question would be how to do this monitoring. You cannot keep on measuring the blood glucose level using a finger prick glucose meter throughout the day. It would be extremely painful, a lot of charting needs to be done, and it would be impractical. So we now have these devices. These devices actually were launched in the late 80s. From 1999 they have been approved by the US FDA, and we now have these devices called the continuous glucose monitoring systems, which consists of a simple sensor which is placed over your skin. It's usually placed over the posterolateral part of the arm, the one which is popular in India. It has an electrode which projects through the skin into the interstitial space, and it measures the interstitial fluid glucose, which sort of equilibrates with the capillary glucose with a time lag of 8 to 10 minutes. So the capillary glucose, it diffuses into the interstitial space before reaching the adipocytes. This interstitial glucose is picked up by this sensor through near field technology or Bluetooth technology. It transmits this information to a receiver, and it transmits this information every 5 minutes, giving you as many as 288 readings per day, and the very latest ones which have been launched measure it every minute, every single minute of the day, giving you even more readings. Now the receiver that I have shown here is somewhat of an antique receiver. The receiver that is used to capture these blood glucose levels every 5 minutes looks more like these which have been shown in the image. Now you can even use smartphone apps tagged to your sensor. You do not need to buy these receivers. You can simply buy the smartphone apps and the results will show you in your smartphone as well. Of all of these which have been shown in the picture, the two which are available in India are the Medtronic one and the one which is shown there, which is the Abbott one. A disclaimer, I have not received any honorarium for speaking in this lecture anyway. So the main difference between the Medtronic one and the Abbott one is that the Medtronic one is a real-time CGM, which means that on its own it keeps on taking the readings every minute or every 5 minutes depending on the generation of the machine that is being used. However, the user needs to check the blood glucose at certain points of the day using a glucometer, a conventional finger prick glucometer, and it needs to be calibrated. The sensor needs to be calibrated with that finger prick reading. And this sensor can pick up at the most 3 to 5 days of glucose data. The more popular one, which is mostly used when we need to use it, is the intermittently scanned one, which gives you 14 days worth of data. You do not need to calibrate it with finger prick, so it's absolutely painless in that sense, except for that single prick when you are inserting the device, and the cost is much lower. However, you need to scan it at certain times. At least every 8 hours, you need to scan the device to generate the last 8 hours worth of data and pick it up using the receiver. So finally, when you have used the device, you get a report which looks something like this. These are the three main things which are found in a continuous glucose monitoring report. So it's not very clear, but what is shown there is that 14 days, so April, 2nd April 2021 to say 16th April 2021, the sensor was there for 14 days. As I said, this is the most popular sensor which is used. If you look at the percent time the sensor is active, 88%. So it was scanned at frequent intervals, as I said, at least every 8 hours. So for a good CGM report, there should be at least 70% of that 14 days worth of data, that is at least 10 days worth of data. So here it was 88% scanning, so this is a good report. If you next look at the time in range, you have a green part which is 55%. So the person is not maintaining more than 70% time in range. And of course there are hypos, about 11% is the hypos, experiencing a lot of hypo and experiencing a lot of hyperglycemia as well. If you look below there, there is something called the glucose management indicator, which is nothing but a derived HbA1c level, which means that from the average that it picks up, it gets hundreds and hundreds of readings. It does an average over those 14 days and extrapolates it to give you the HbA1c level for that 14 days. And this actually is possibly even more accurate than the HbA1c which we get from the laboratory, because we know that there are factors influencing the glycation of hemoglobin. There are factors altering the lifespan of RBC, all of which can be overcome if you simply measure the interstitial fluid glucose. So it gives you trends in HbA1c, a very accurate measure of HbA1c. If you look at the graphs that you get with this device, you get each individual day's data, Saturday, Sunday, Monday for 7 days and another 7 days. You get all the peaks and troughs over the 14 days. And all these 14 days glucose is again put into, using the software, it's put into a single day called the standard day or the modal day. The graph which you see above, it's a combination of all those 14 days data. It has a central blue line, that's the median glucose over those 14 days, the central blue line. Above and below the central blue line, there is a slightly dark blue zone, which is the 25th to the 75th percentile, the so-called interquartile region, which is about 50% of the values over that period. And you have a lighter blue zone above and below, the 5th to 95th percentile, the so-called interdecile zone, which again is wider fluctuations over those period. Beyond that, everything is an outlier. So just to give you a brief idea, again, continuous glucose monitoring system is very complicated. Even I don't have 100% understanding of the same, but I'll just give you some basic idea of what we can derive from it. So as I said, there's a 50% zone, the interquartile range, and a bigger zone, the interdecile range. The interquartile range, if you look at the second example, if the interquartile range is wide, it means that some therapeutic problem is there. The dose of insulin is not correct, or the insulin and the carbohydrate in the meal is not matched well. On the other hand, if the interdecile zone is wide, 5th to 95th percentile, it's a behavioral problem. The patient misses insulin, does not exercise, takes a lot of carbohydrates, misses a meal, etc., or consumes alcohol frequently. So practically, how can, if you look at the overall picture, how can the continuous glucose monitor help us manage diabetes better? If you look at this example here, you can see that this patient is experiencing hypoglycemia at least at 2 points of time, early in the morning and in the post-lunch period, when the median, the 50th percentile line is dipping below 70 milligrams per deciliter, and of course, the interquartile range, a part of it is also going below that zone along with the interdecile range. So this helps us identify the problem, the time of the day. So he could be taking too much of basal insulin at night, or taking too much of a prandial insulin, or going for a jog early in the morning without taking any carbohydrates, or consuming alcohol at night. This graph will give us an idea of when and how frequent hypoglycemia is happening. It's the same with hyperglycemia. If you look at this graph, this person has, if you look at the bottom, the x-axis, of course I should have told it earlier, the leftmost point is 12 midnight. The rest is the night part of the day, the morning, the afternoon, the evening. So you move from 12 midnight to 12 midnight as you move along the left axis. So here again you see that this person has nocturnal hyperglycemia, post-lunch hyperglycemia, post-dinner hyperglycemia. So the post-dinner hyperglycemia is possibly contributing to the nocturnal hypoglycemia, and there's a post-lunch hyperglycemia as well. So he's either taking a lot of carbohydrates at night, or the insulin dose at night, or the insulin dose before lunch is infrequent for this given individual. And there are individuals who have a lot of variability, but if you look at their pattern, they show an interesting pattern. For example, if you look at the individual day pattern below, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday, Monday, over 2 weeks, you'll find that most of the problem is happening at the weekend. Friday, Saturday, Sunday, there's a lot of hyperglycemia. So he might be not exercising on those days, or consuming alcohol, going to parties on those days. So it also gives you an idea of the specific lifestyle factor on a given day of the week, which might be contributing to the problem. So I've put in 2 basic case studies just to give you an idea of how it might help improve our practice. So this is a 52-year-old man with 21 years of diabetes, has developed severe retinopathy, A1C not controlled 12.2, complaining of fatigue and symptoms suggestive of distal peripheral neuropathy. He is taking 10 units of glargine, twice daily metformin, 1.5 milligrams of dulaglutide, a GLP-1 receptor agonist, and 10 milligrams of glipizide at lunch. However, with the glipizide, he is a bit stingy. He says that I often don't take glipizide because I feel that if I take glipizide, I feel like sweating after lunch, I might be experiencing hypoglycemia. But although he says that he sweats after taking glipizide, he has almost never measured his blood glucose, and he says that he is a busy executive, too busy to measure his blood glucose at different points of the day. So for a person like him, if you put him on a continuous glucose monitoring system, he can continue with his busyness, but you can get an idea of what's happening throughout 24 hours or throughout 14 days at a stretch. And what this graph shows very clearly is that, I won't go into the much details, but if you look at the standard day or the modal day, you can well appreciate that the upper green line is 180 milligrams per deciliter. Most of the time of the day he is spending above 180 milligrams per deciliter. The 50th percentile most of the time is above that 180 milligram per deciliter mark, and he's never experiencing hypoglycemia. Even the 5th percentile line is above 70 milligrams per day. So you can use this as a visual tool for educated patient to counsel the patient that, look, this is what is happening. You have already developed complications. You are on the road to a bad outcome. So using this as a visual tool, you can shift the patient now to a basal bolus insulin. So this can be an educational tool as well. Shift the patient to a basal bolus insulin and do a repeat continuous glucose monitoring just to show him that yes, things can improve if you follow the rules properly. So this is another second case, another man, a 71-year-old man with 30 years of diabetes. He has other comorbidities as well, hypertension, dyslipidemia, cardiovascular disease, kidney disease, A1C 8.9. He has developed moderate renal dysfunction. He is on gliclazide twice daily, metformin twice daily. He occasionally forgets to take his medicines, and although it's not very clearly visible, he was put on a continuous glucose monitor, and it was found that it was only 16% of the time that it was used, which means that he was very reluctant about treating diabetes. He had a lackadaisical attitude, let whatever happen happens. He spent money on putting a sensor, which is still quite costly by Indian standards, but he did not bother to scan the sensor. So this just shows that in this individual, what is required is not any costly therapy, but simple good counseling. If this individual can be counseled well about his dietary pattern, exercise pattern, to stick to his drugs, DAPA was added given the renal dysfunction. Again, a simple good dietary counseling, using it as an educational tool, can help improve outcomes. So in type 1 diabetes, there's a lot of data to show that it helps improve outcomes. In type 2 diabetes, the data is limited. There is some limited data in gestational diabetes as well, but it has shown that particularly those requiring several shots of insulin per day can improve outcomes with the use of this device. So if you are thinking of using a continuous glucose monitoring device, you can consider almost any patient with type 1 diabetes to be a candidate for the same, provided affordability is there. Type 2 diabetes receiving multiple pricks of insulin, difficult to control A1C, having hypoglycemic unawareness, severe hypoglycemia, recurrent hypoglycemia, nocturnal hypoglycemia. These are the individuals who can be considered for a continuous glucose monitoring system. So to sum up, this is a technology which is now available. It's still somewhat expensive by Indian standards, but if you can use it, it helps communicate your concern to your patient better. You can give the patient a visual representation of what is happening, where things are going wrong. After giving treatment, you can repeat it to see how your drug is working, and at the end of it, it gives you a better quality of life. Technology has changed the way we treat diabetes, and continuous glucose monitoring system happens to be the one of the latest kid on the block to help us improve outcomes. And just to give you a taste of how technology changes things as well, this slide specially, I've designed it using an artificial intelligence app called Gamma. If you look below, you just feed your query in the app and it gives you a slide. So just to give you an idea that technology is changing the way we are doing things, this is available free of cost, but continuous glucose monitoring is not. When prices come down, hopefully it will be of much greater use in our day-to-day practice. Thank you.
Thank you very much, and wonderful presentation indeed. I think we'll have a couple of minutes for some questions, comments from the audience.
I just wanted a small question of
yes, sir.
What is the cost of these
right.
The latest one?
So if you put it in for 14 days, initially there is a one-time investment for that app or that sensor, or that reader rather, which is around, I think, about 5,000 to 6,000 rupees now. And if you do it every 14 days, the cost would be around 4,000 rupees.
So why would there be a cost, once you've bought that?
Now you have brought the reader or the mobile phone app, but the sensor you need to change it every 14 days. So that has a cost as well. In fact, there are two types of instruments which are available. One is a professional CGM,
right,
which the doctor can insert. It's actually less costly. But the patient has to come after 14 days and you scan and you give the last 14 days worth of data. Another is a personal use CGM, which is about 4,000 or 4,500, a bit more costly, where the patient can do it on a sort of real-time basis at his or her home. So that's a bit more costly.
It's wonderful. Any other comments?
So the cost of one time using it is like 4,000 to 8,000?
Roughly around 4,000. So if you use it for the entire month, it's around 8,000 rupees.
It's a single use device.
Single 14 day.
14 days.
14 days single use.
No, but that the device can be reused.
The reader is there,
Reader is there.
but the sensor after 14 days,
That has to be
it loses
dispensed.
all its enzymes and everything
mean-
that is there. It doesn't work anymore.
Okay, okay. That was great. I think it has been a very lucid presentation. It apparently it was complicated, but then you have made it very simple.
Excellent, and the slides were just too good.
Too good. I was only trying to add the fourth this thing into it, that this kind of device or use of this kind of device can also help us as a tool for research.
So I did not put the research part because I'm not very well aware of that part. It belongs
Because,
to your domain. I'm more of a clinician.
Right.
But yes, we can extrapolate these
Absolutely.
findings to the research part.
Absolutely. Dr. Mukherjee was referring to actually the monitoring in academic research. And these are the kind of tools that can actually enrich our academic research in real life situation, and with your patient registry and use of these kind of tools in your patient management. And then the data can be collated and we can see what is the extent of problems in diabetes management and glycemic control. What is the real situation? As we always say that it's not really very otherwise satisfactory, but here we can generate objective data, and by collating them you can already you can think of having good quality academic research also. Thank you very much. Wonderful job done. No, that's a
There's an app
Artificial
called
intelligence.
Gamma. You just
Yeah,
go to the Gamma app. If you put in a query, actually it gave me a 10-slide presentation. But I just kept the last slide just as an example to show how technology is changing
you
things.
just type your keywords.
You type your keywords
And it will come.
It just gives you a framework to work on. It
Right.
doesn't give you a great presentation.
So something idea put into visual.
I just
Right,
put the last slide. The rest is manual. Human intelligence.
of course.
So we had actually done one small work with this CGM, and that was a 14 days study. So what we did first 5 days, we used Ishpagula husk, Ishobgul pre-meal.
For diet, for lifestyle modification, this is a very good app.
Yeah.
Very good.
And we found
Very
there
good
is a
tool rather.
statistically significant decrease in PP sugar. The
That's right.
postprandial values are
Any
going
sort
down.
of dietary fiber will help smoothen the variation.
So we had
glycemic
done
variability.
one small pharmacodynamic study in STM only under the SIR's guidance. One thing just I'm thinking about, because now the generic thing is coming up, whether this could be also useful
Absolutely.
in seeing the pharmacodynamics of anti-diabetic agents, switching from one brand to another brand, whether there is some
Any
differences.
change. So there are studies actually like remogliflozin versus dapagliflozin. There is a pharma-sponsored such study where they have looked at this, whether there are differences in parameters. So there are some studies which have tried to look at these drug versus drug or changing from drugs with the use of these agents.
Yeah.
In
Small
fact,
studies
in
are there.
any diabetes trial, the efficacy endpoint, that can be always,
And
this can
all
be
these
used for.
trials are in the tune of 50, 60 or 100, 150 numbers at the most because of the cost involved.
Absolutely.
It doesn't go into thousands.
So thank you very much. I think we can end the session here. Just a second, I think they're going to do some honors.
So may I request Professor Shantanu Tripathi sir to felicitate Dr. Soumik Goswami. Thank you, sir. Thank you very much. So now we are moving towards the next session, and that is on oncology. And we have two speakers from outside who will be joining virtually with us. But we are really privileged to have with us Dr. Madhu Chanda Kaur, who is a very noted clinical oncologist in this country. So she will chair this session, and we have two talk here, madam, because of some travel related issues. Dr. Devashish Hota had to leave early, but we have Dr. Prafull Mohan and Dr. Pooja Gupta. So with your permission, I just want to introduce the speaker and you can start the proceedings. No. So, yeah, that was already done because he had to leave. He had to leave early, so Dr. Prafull Mohan, the first talk will be delivered by Dr. Prafull Mohan. He is a very noted clinical pharmacologist and currently attached with Army Medical College Pune, AFMC, as Professor of Pharmacology. Welcome, sir. And also we have Professor Pooja Gupta, who is a professor, who is also an noted clinical pharmacologist in this country. She is now professor at Department of Pharmacology at AIIMS, New Delhi. So welcome, madam. Now over to Dr. Madhuchandakar.
Thank you, organizers, and special thanks to Professor Tripathi and Shambhu. I think we have very important speakers and session over the next half an hour. The first is welcome Dr. Prafull Mohan. It's on drug targets for cancer. I think in no other vertical of medical science, every day drug targets are changing. I mean, after we finish the symposium, maybe a new drug target is coming in cancer. And again also in diabetes, I think a lot of research is going on. So we are all really excited to hear from Professor Mohan what awaits us in the vertical of cancer as far as drug targets are concerned. Over to Dr. Mohan.
Good evening, ma'am, and good evening, my teachers who are there, and also friends. At the outset, kindly let me know if I'm audible to all of you.
Yes, you're audible. Perfect.
Correct, ma'am. Thank you. And at the outset, I apologize for not being there, which I wanted to do so much. But anyway, technology, let's take the help of technology. And I would like to just share my screen and so that we can go ahead. Is my screen visible, ma'am?
Yes. Go to slideshow. It's visible.
Just a minute. I think I'll just take a moment to put it. Just a minute. I'll just take 2 minutes to. Yeah, I think this is it full screen now, ma'am?
No, slideshow is not there. Full screen, yes, now it is. Now it is. No.
Is it there, ma'am? Yeah, I can see it's there, right?
Yes.
Yes, it is there. Ma'am, can I go ahead?
Yes. Yes, please proceed. Please proceed.
Yeah. So, over the next 15 minutes, ma'am, I would want to talk about the cancer cell ab initio, what makes it so special. That's going to make it easy for us to understand how to target it. I would also give you a small glimpse of the conventional anti-cancer drugs and what's wrong with them. Then go on to the targeted therapies, the new targets, and the emerging concepts. So, in fact, I was thinking loudly and was telling myself, like the chair also alluded to, that this is a topic which can be talked on anytime. It can be talked on for the next 20 years as well, because this is such an expanding field, and rightly so. So, about the cancer cell, basically 2-3 things make it special. It's like a naughty child in the class, which cannot be controlled by their teacher. We face them so many times. And it is also characterized by the capacity to proliferate abnormally, invade other tissues, and spread to distant locations. And to do all this, it has some special needs, some of which we have been able to exploit to target it. Really, most of the times, there is a genetic mutation behind this cancer cell. And most of the times again, there would have been an immune response to nip the evil in the bud, but it does something so that the immune response doesn't mount on it. And as our understanding of cancer biology increases, we now understand that cancer cell is not a solitary entity. It cannot be tackled in isolation. So it's a part of a microenvironment around it which contains a lot of things, but essentially it contains immune cells, fibroblasts, extracellular matrix, and neural elements also. So it's a dynamic relationship between the cancer cell and the environment around it. So there will be targets inside the cell, and there will be targets outside the cell also. And as we go along, we are trying to tackle or identify targets outside the cell. So this is just a glimpse of certain conventional anti-cancer drugs. I will not talk about them much because willy-nilly most of us know about them, including the students. But the problem is that all of them have got narrow therapeutic index and they reduce the quality of life substantially. They're more like a big bomb which falls on a small village and kills hundreds of persons, whereas the target was to kill only one individual. And that's the reason why it has so many problems, and that's the reason why we keep on talking about newer targets and how to make it better. And if you can see that most of the conventional anti-cancer drugs are focused on somehow stopping the multiplication of the cell by attacking the DNAs or the RNAs. Of course, there are certain cells, certain cancers, which we know they are driven by hormones. So we target those hormones and try to stop those cancer cells or kill them. So what is a targeted therapy? Targeted therapy consists of those drugs which are targeting specific molecules which are associated in the growth or spread or progress of a cancer cell. So far, most of the targets which have been identified are oncoproteins. So basically, oncoproteins are those driver proteins which would drive the growth of a cancer cell. Oncoproteins would be produced because of oncogenes or proto-oncogenes. We talked about the mutations which are behind every cancer cell. So a mutation gives rise to oncogene, a proto-oncogene and an oncogene, which gives rise to oncoprotein, and then we try to target these oncoproteins so as to make our therapy more focused. So these oncoproteins can be of two types. They can be those proteins or targets which are essential for the survival of the cell. They can be those proteins which help the cell escape the immune response. We'll try to talk about them as an example. So basically, it's more like a sniper. You identify a particular cell and you only want to kill that cell and not cause any collateral damage. So some of the targets have already been exploited. There are drugs, already targeted drugs in the market, are being used clinically. We'll talk about some of them so as to understand how the targeting goes around. If we understand how we came here, it will be easy for us to understand how to go ahead. So I'll just talk about 3 representative examples of those targeted therapies which are already there in the market. We all know about them, but just to put the entire talk in context. So imatinib, which is a signal transduction inhibitor, its role in chronic myeloid leukemia. So we have a genetic mutation which gives rise to Philadelphia chromosome. We have a oncoprotein BCR-ABL, which gives rise to CML, and we have a drug which will block BCR-ABL, or would rather block its tyrosine kinase activity. So one genetic mutation, one target, a drug which blocks the activity of this target, and we have a much better treatment of a disease which was not so well treatable before imatinib. So in this we are trying to target something which is intrinsic to the cancer cell. Let's take the example of bevacizumab. As I had alluded to in the first slide, cancer cell is dividing rapidly. It will have immense metabolic needs. Most of the times it will be in a state of hypoxia. Hypoxia will stimulate production of vascular endothelial growth factor, which will dock onto its receptors, VEGF-R1 and 2, and bring about angiogenesis. So if you stop this angiogenesis somehow, you will starve the cancer cell. It will not be able to grow, and that's what we do by bevacizumab, which is a monoclonal antibody against VEGF. Of course, you can block the VEGF receptor as well, which we do with other drugs. So point is to stop angiogenesis. So clearly, ladies and gentlemen, in this case, we have tried to target something which is outside of the cancer cell. Example of extrinsic or the tumor microenvironment based target. So this is fairly straight, 2 plus 2 is equal to 4. Let's see, it doesn't work like that every time. Let me talk about trastuzumab. Old drug been in clinical use for quite some time, a long history of development. So you identify a particular gene which is overexpressed in a particular type of cancer, that is breast cancer. You make a humanized monoclonal antibody against it. You dock it onto that target, and you see that the cancer cell actually dies and is clinical relief. Here the problem is that 2 plus 2 is not equal to 4. We still don't know how it works. I have given a reference of a very good paper. Those of you who are interested in how the science progresses, this will make a good reading. So there are theories about how trastuzumab will act. It is seen to be acting by causing dimerization and inactivation, phosphorylation and inactivation, endocytosis, and so on and so forth. But it works. So at the end of the day, trastuzumab works. How it works, we don't know. So idea is that you have a target which you see is getting overexpressed all the time. You make a molecular antibody against it, you block it, and you see that it gives rise to clinical benefit, and you start using it. And then, of course, we are trying to find out how it works. It doesn't matter, of course, as long as it works. Of course, it does matter. I'm sorry, I should not be saying this, but it works. So these are the 3 examples which I wanted to talk about. Now, there are certain new examples also, like tropomyosin-related kinase inhibitors. So tropomyosin-related kinases are basically transmembrane proteins that are important and required for cell differentiation and growth. They are encoded by a well-identified gene, which if mutant can give rise to fusion proteins or fused proteins, and these fused proteins have uncontrolled activity. They can lead to cell differentiation and growth without any external stimulus. So again, you have a gene, you have a mutation which gives rise to abnormal protein, and you block that abnormal protein by small molecules, larotrectinib and entrectinib, and that affords clinical benefit to patients. A very newer thing. I think it got, if I'm not wrong, it got approved in 2017 or 8. Now, another curious example is, now we are going from targets to epigenetics. So basically, mutated FLTs, they autodimerize and they drive cell growth in absence of any external stimulus. So again, you have agents against them which target specifically these kind of targets, and then they give they produce symptomatic, cure used in CML. Now there is a very interesting concept of synthetic lethality. So in synthetic lethality, it's basically a conjoined attack by 2 agents. In isolation, they will not be able to work. So basically you have something known as PARP inhibitors. PARPs are required for repair of DNA damage. So a single onto your left hand side is the normal cell response, whereas a single stranded DNA will be repaired by PARP by something known as the base excision repair. And the cell survives. Now, if you inhibit this PARP, this single stranded DNA goes on to develop as the double stranded DNA break. It cannot any longer be, of course, you have blocked the PARP. So this single stranded break develops into double stranded break, and then it can be only repaired by homologous reconstitution, for which we require something known as BRCA1 and 2. So if BRCA1 and 2 is also mutated and deficient, and in that subset of patients you give PARP inhibitors, then they would ensure that the cancer cell gets lysed. So that's why PARP inhibitors are useful, are approved for ovarian breast cancer, which are BRCA positive. If you give these drugs in BRCA negative patients, wherein this HR dependent pathway is intact, then they will not have anything. So there is a case where there is already some kind of a mutation which makes the cell vulnerable to something else, and you give that something else in the form of PR. So this is a synthetic lethality concept, which a lot of work is going on this at least. Now coming on to immunotherapies. So immunotherapies, I've already briefly touched upon the importance of immune response. So why not exploit the immunity to block or to treat the cancer? So very interesting, I would say, class of drugs which have emerged in last 6-7 years is the immune checkpoint inhibitors. So basically, they boost anti-cancer immune response, which had been lulled by the cancer cell. So basically, there are 3 targets: PD1, PD-L1, and CTLA4. I have already given the list of all immuno checkpoint inhibitor drugs which are already in the market, and again a fantastic summary which got published in 2022. So I'm sort of trying to not go into too much of details about it so as to cover most of the points, but giving you the material all along. Now another important or very curious therapy which is very, very personalized is adoptive cell therapy. So basically you take T cells from the patient and infuse them into the same patient. It's again of 3 types. There is something known as the T cell therapy, in which there is no genetic modification of the T cell is required. You just take T cells from the individual, infuse it back into the same individual, and hope that they works better and the immune response is better. In other type of T cell therapies, you do some genetic engineering of the targets of the T cell, infuse it inside the patient again, and then hope that this targets on the T cell will elicit the immune response against the cancer. So the given, this is little, I would say, for the students, little difficult to understand, but the reference which I have given, it's one of the simplest summaries which I found on this subject. I've taken the photographs also, picture also from there. So now, refining the old idea, this is a very curious example of 2 drugs, antibody drug conjugate. We know that a lot of drugs are targeted against folate metabolism to treat cancer cells. In fact, folate receptor alpha is overexpressed in a lot of cancers. However, a humanized monoclonal antibody was not able to produce symptomatic relief or was not able to produce clinical effect in trials, which was targeted against folate receptor alpha. However, when you use it as an antibody conjugate, targeting against the FR alpha and conjoin it along with a microtubule agent known as albumin. So it becomes a typical antibody drug conjugate, wherein the FR alpha, folate receptor alpha antibody, is not doing anything to the cancer cell. It is just it's being used as a decoy to put albumin inside the cell, which leads to cytotoxicity. So this is how the farletuzumab, which could not produce clinical benefit in phase 3 trials on its own, can it still be used in some other way as an anti-cancer drug. Now, another refinement of the old idea, we all know that antibody drug conjugates were a very famous, were a very frequently, or I would say widely studied arena about 10-15 years back. But because of the large size of the antibodies, a lot of them did not find success. Same thing has happened now. Now bicyclic peptides, which are much smaller than antibodies, are being used to sort of deliver a cytotoxic substance. In this case, MMAE, a tubulin inhibitor. So Nectin-4 is a target which is overexpressed in bladder, breast, lung, and pancreatic cancers. So you have a peptide which identifies this Nectin-4, docks onto it. It has MMAE along with it, and that goes inside into cytotoxicity. Now coming to emerging concepts. So one thing which has not been studied so far is the importance of protein-protein interactions. I'm sorry for this spell. The spelling of one of the proteins is wrong. Sorry for that. So basically, we have been talking about gene, the epigenetics, and the target, but we don't know how proteins interact with each other and where can there be any target between these proteins. So OncoPPI is protein-protein interaction network. It's a kind of a network which studies about protein-protein interactions so as to find some other targets if possible. Then metabolic vulnerabilities. Cancer cells have special needs. I've talked about that. We also know how we exploit these needs by way of FDG PET so as to identify where the cancer cell is lying. Something similar happens. Cancer cells, some of the cancer cells also have more production of or more requirement of 2-hydroxyglutarate. A lot of work is going on blocking 2-hydroxyglutarate production so as to stop cancer cells. Similarly, also to stop serine synthesis, which is essential in development of certain cancers. A lot of cancer cells also have enhanced requirement of lipids. However, it is very difficult to target those because we have the understanding of cancer lipidome is limited as of now. But this is another area where a lot of work is going on so as to identify how do we starve the cancer cells with lipids. Another emerging concept is the concept of proteolysis targeting chimeric technologies. So you attach small molecules with some agents which destroy a particular target protein via the ubiquitin proteasome system. So instead of targeting the gene, instead of targeting the epigenetics, you just identify protein and try to kill it. And of course, then at the end, there's emerging concept of cell states, which says that a cancer, a body of cancer cells, I would say, will have mix of type of cancer cells. Some of them would be trying to metastasize faster. Some of them would be in a stable state, and the tumor microenvironment around the cancer cells will determine which stage the body of cancer cell lies. The most important of them is cancer-associated fibroblasts. So a lot of work again is going on. This is an emerging target that how to change the cancer-associated fibroblast so as to stabilize a particular cancer cell in a particular state, stable state or unstable state. So these are certain things which on which again emerging concept on which work is going on. So ladies and gentlemen, this is the target tree. Again a fantastic review. Kindly read this. So it's the last slide. So you have targets which are intrinsic. We have talked about oncogenes. We have talked about chemosuppression. Epigenetics we have talked about. Synthetic lethalities we have talked about. DNA damage we had also talked about. OncoPPI network, it has yet to throw up something of translation value, but this is very promising. And again, metabolism, some of it has been exploited, some of it remains to be exploited. Onto the right hand side, tumor micro environment targets, immune checkpoints we have talked about, adaptive immunity and innate immunity. So basically, T cell adaptive immunity is something which is already in the works, already approved, highly personalized. And of course, cancer-associated fibroblasts I talked about. Angiogenesis, a lot of work has already happened. It's Vivastin was an old drug, a lot of work is still going on. Thanks, I think that was all I could, sort of clubbed into a 15-20 minute time slot. I hope I have not overshot my presentation. Thanks a lot, ladies and gentlemen.
Thank you, Dr. Prafull. I think it was a very detailed and methodical presentation. We can have one or two comments or questions. Yes.
Ma'am, I'll just take a moment. I think there is something wrong with the audio.
Audio, you can't hear? Can you hear now?
Yes, ma'am. Yes, ma'am.
Okay.
I think I can. Yeah.
Can I have a mic?
Professor Obijit Hajra will... yes, please give him.
Actually...
Can you hear?
Can you hear us, sir?
Ma'am, just a minute. Ma'am, I'll just take a moment. I'm not really able to understand what's wrong with it because... Yeah, ma'am, I should be fine now. Yeah, please.
Okay. Dr. Mohan, first of all, thank you for giving us a rapid overview of this emerging field of targeted cancer chemotherapy. So as you rightly said, that the future of cancer chemotherapy lies in targeted therapy. There is no point in bombing all the cells with traditional cytotoxic drugs. But when it comes to reading and studying, it's all very difficult. leave aside undergraduate students, even for postgraduates, the field is very difficult to grab. So, with the review we have done recently, may I ask you that if you were to narrow down, keeping the next 3 to 5 years span in view, what are the most promising targeted therapy areas of the many you have mentioned and the many more which are emerging every day? If you were to narrow down to, let's say, 3 or 5, which are the most promising areas?
Yes. So, thanks for your question, sir. I think I should have covered it myself, but anyways. So to my limited wisdom, I can say that immune checkpoint inhibitors would have been a great, area of promise. However, so far they have not been able to show that kind of clinical efficacy and at that cost. So I think that something like we have to probably attack it from the two sides. Choose a target which is in the microenvironment and choose a target which is inside the cell, integrated to the cell. So I would say something like an immune checkpoint inhibitor coupled with something which starves the cancer cell. Maybe as we understand cancer lipidome better, maybe something which stops production of a critical lipid. And something which makes the cancer cell more vulnerable. So, if I may answer the question very honestly, again, limited wisdom, sir, any single agent won't be able to do that because willy-nilly the cancer cell, by virtue of its development, will find a way out. So, it's going to be kind of a two-pronged attack over it. So, I think that's the best way I can answer that, sir. And in between these two things, if you want really need to sort of identify, then probably immune checkpoint inhibitor on one side and a tri-hydroxybutyrate inhibitor on the other side or something like that. But our problem is that the physiology of the cancer cell, the energy needs of the cancer cell beyond its requirement of glucose are not very well as of now. So I think this is what I have to say, sir, and I would like to hear some voice from the learned audience and stand, move by the us.
Okay, thank you, sir.
Thank you. If I may put some comments, we began with cancer chemotherapy killing the cells. Then we thought we have found some targets like imatinib, which will be more specific. And then we found that this tyrosine kinase inhibitors started growing resistance. So to block the resistant pattern, we went downstream signaling. So we picked up PI3 kinase in the resistant pattern to block PI3 kinase. And then we learned that no, there is something else we can do. We can have anti-angiogenesis. But we found that anti-angiogenesis alone will never work. It has to be combined with the chemotherapy. Then we learned, okay, why not combine chemotherapy with the tyrosine kinase inhibitors? Initial trials were negative, but then some positive trials in lung cancer have started coming. Then we have something unique, that is immunotherapy. Body's own immune mechanism will take care of the cancer cells. By what? We promote the immune system, and that is what is immunotherapy. And recently, there are umpteen of trials which are combining immunotherapy with chemotherapy to get the maximum benefit. So actually, no one target will ultimately fulfill. To get more and more better results, you are combining chemotherapy with immunotherapy, even with anti-angiogenic therapy, triple therapy we call it. Yes, for these what has happened is the goalposts of adverse events have changed. What was vomiting, nausea, diminished cell count has shifted to metabolic derangements with hypothyroidism. Target therapy have also caused diabetes, and immunotherapy has given rise to a host of autoimmune diseases. So the goalposts of adverse events have changed, and recently if you look at the immunotherapy trials, what is very unique is we also get to learn that there is some pseudo progression. Suppose there is a lung cancer, you've seen the cancer size, and next when you give the immunotherapy, the patient is okay, he feels better, but your lesion in the lung shows some slight progression. So do not react to that. The patient is clinically stable, you continue with your treatment, because this is nothing but pseudo progression. So days are going by and cancer treatment is becoming really interesting, at the same time more complicated, more costly, and more combinations are coming to stay. Thank you.
I have a couple of questions. Can I?
So ultimately it's a model child, ma'am. We need to find ways and means to control, and it will try to hold our control.
Once we control this, something else is flaring.
Something else will come. So it will keep on having model ideas.
It's clever.
Prafull, I had a couple of questions for you. And if you haven't looked into those areas, then feel free to say that you're not aware of it. I wanted to ask you about PRMT5 inhibitors. I have a specific question. So PRMT5 inhibitors are a new class of anti-cancer drugs that are being developed. I think there are 5 or 6 candidates in development right now. Now PRMT5 works within the spliceosome, and they are protein arginine methyltransferase is the name of the enzyme, and what it does is it methylates arginine in the histones. Now, this enzyme is there in all cells, of course, and so when you inhibit this enzyme, you would expect all cells to be affected. But I hear that PRMT5 inhibition, cancer cells are more susceptible to it than other cells, and I have not really understood that. So if you can clarify, if you have that knowledge and if you have read up about that.
So frankly speaking, I have not delved into this much, but this pretty much happens with whenever we are trying to tackle a particular metabolic need of the cancer cell. So it's not that this need of the cell is unique to it. It's just that the need is more than the other cells. So when we say that the cancer cell uses glucose and more, it just uses more glucose. So I really don't know how to answer the question. So probably the question is that why certain cancer cells.
You are no longer audible, Dr.
Hello.
Yeah.
Hello. So,
yeah, we can.
You are audible.
So you have to unmute.
You're muted, Prafull.
Mute.
Yeah. No, you're muted again.
Sir, you have to unmute. Yeah.
Yeah, am I muted now?
Yeah, now audible.
Yeah. So I understand your question correctly. It was about that why certain cells are certain cancers, why they are still not responding to it. Is that so, sir?
No, my question was.
Why the lysosomes, which are present everywhere, why specifically they attack the cancer cells?
The spliceosome, so
Yes.
splicing of the DNA.
Why that occurs only in cancer cells, not in other cells? If you know the answer, sir, I don't know.
So, frankly speaking, I have also not delved into this, but only attempt, maybe because of the rapid rate of multiplication of the genetic material, probably.
Yeah, no problem. The other question I had was more to do with actually the clinical trials for development of anti-cancer drugs. So, phase 1 for the development of anti-cancer drugs is, as we all know, generally carried out in patients, unlike phase 1 for other chemical molecules. Now, when you do that, and cancer is something that is often treated with multiple medications, multiple drugs. And phase 1, the objective is to be able to say what the toxicity profile and the tolerance profile of this new medicine that you are developing is likely to be. So if you are going to add that on to existing therapy, then the amount of information that you're going to get is going to be pretty muddled because you have several drugs being given to the patients. On the other hand, whether it is okay then to use, and how have you what do people do in phase 1? Do they use single agents, particularly for the newer type of agents that are coming up now, the targeted therapies? Are they using single agents in phase 1, or are they using it on top of the standard therapy? That's my specific question.
So basically, sir, when you join two drugs, one of them would have some kind of established action. So you have some drug which has in most of the combinations which have been used, a drug will have some kind of at least one drug will have some established action with known profile, and then you add something new to it, because either by then the cancer cell has developed resistance to it, or it was, safety wise it was undeniable. So at least one agent will have sufficient understanding about it. So it's not, I would say, a blank blackboard on which we are trying to create painting with two pens simultaneously.
Actually, if you look into the cancer trials, phase 1, most of
So I think this Dr. Pooja is covering the endpoints.
Most of the drugs in phase 1 have been in advanced cancer, where the patients have already exhausted most of the lines of treatment. So that is how a new drug develops in cancer.
Right. So would you think
we don't try it in adjuvant, we try it in metastatic or advanced setting. Yes.
Yes.
Just one point to add to sir's questions. If you look at the recent phase 1 trials in cancer which are being published, they're doing it with single agents, because it is not a therapeutic intent. It is to define the basic pharmacokinetics of the drug, but they have to do it in patients for obvious reasons. But they're doing it in single agents because there's no therapeutic intent behind that.
Right. So would it generally be considered by ethics committees in India, for example, to be quite okay? Ethically, that would be your own ethics committees.
Yeah.
You would consider that quite.
We don't consider too many phase 1 trials, only a few we have considered, but that's done mostly as a single agent.
Sir, it is an orphan situation. You have exhausted everything. You want to use something.
So ethics committees would consider that quite.
Very few patients, and those who have exhausted everything in the advanced setting, they usually get a new drug phase 1.
Okay.
In cancer, that is the dictum. You don't do in a operated patient. You do it in advanced or metastatic setting where you have done all the standard treatment already. And then a single agent, as he said.
Right. Okay. Great. Thanks.
Okay, let us know. Thank you. We had a very fruitful discussion. I think give a big hand to Dr. Prafull for inciting talk. The next one is equally important, I think. The endpoints in cancer trial, and Dr. Pooja. Dr. Pooja is here. Dr. Pooja Gupta.
Yes, ma'am, I'm here.
Okay. Ma'am, please take up the issue.
Can you stop sharing the screen so that I can share time?
Yes. Just a minute. Just a minute, ma'am. Just trying to do this. Just give me a moment, I'm just trying to do that. Just a minute, I'm so sorry. Okay, what I'll do is I'll exit for a moment and then join back. I guess that will be probably better.
Yeah, I think.
I'll do that.
So
That's easy.
Team Clarinet, can you help us? Hello, Clarinet.
Yeah, stop share. Done. Thanks.
Done.